Perfect. You're good to go. Go ahead.
Okay, good. I think I hit the wrong one. All right. So we still have a fantastic program for y'all today. Double take. So this is the Scene Lab Presents Eradicate TRD, and today is episode 1. So the first one ever, and we're so grateful that you all came to. So you want to start a diabetic retinopathy screening program. So we have people from all across the country. So we have Lauren Daskivich here that's coming in from LA, all the way to Ben Sean, who's coming in from Delaware, and our favorite girl, Dr. Paula Ann Newman Casey, that's right in the middle in my home state of Michigan. So we're so excited you could make it, and we're going to get going. I wanted to start today to really kind of ground ourselves. So these are some community partners that we work with, and we understand that now there's a lot of challenges. So our Jamaican colleagues and community members that lost so much in Hurricane Melissa. So this is our community partner that really works to help our Jamaican New Haven connection. So they're here, and you can have an opportunity to be able to donate with them. And then also our food pantries across the country are going so low because of the shutdown and the challenges that they're having to be able to feed our most vulnerable population. So this is our food pantry. So we do a lot of work in the Dixwell community neighborhood in New Haven, and this is the food pantry that is there. So if you have a chance, we would love for you to be able to donate to them and also donate to your local food pantry, because food insecurity was already a challenge, and in this current environment, we're really struggling. And a lot of what we're talking about today is related, and we know diabetic retinopathy is associated with food insecurity and a lot of other social needs. So I just wanted to ground us with that as we have a fun conversation about what to do, but really understanding the context in which we're doing this work. So we have a fantastic crew today, and we are so excited that they're here. And I have a little bit of an anecdote to start with each of them. So Dr. Daskivich, I actually met because she is maybe the only, she can tell us, Robert Wood Johnson Fellow that is an ophthalmologist. And so when I was thinking about my path as a trainee, I had cold called her to see what her journey was. And now she just leads a beautiful enterprise in LA County and really helps us to really figure out how to leverage technology and the safety net through her scholarship and through being one of those community partners with industry and otherwise. She's really, really fantastic. And then we also have Paula Ann Newman Casey, who is one of the associate chairs at the University of Michigan. She is a celebrated researcher and really allows us to really understand the details of glaucoma, but also teleophthalmology. And her work within the CDC has really helped us to really conceptualize the how. I think what we've learned and what we'll celebrate for her over time is, how do we think about adherence? How do we think about people taking their drops and what that looks like? She has everything from bioengineering grants to motivational engineering grants to CDC grants and teleophthalmology with federally qualified health centers. And we are so pleased to have her come today. And then we are absolutely delighted to also have Dr. Ben Sean with us today. And he is working with Christiana Care and associated with Temple. And the way that we met was through the American Academy of Ophthalmology Leadership Development Program. And what I think his special gift about his presentation today is, how do you marry the advocacy organization and organized medicine with us trying to figure out how to do diabetic retinopathy in the safety net? And what he and his team is teaching us all on this academy stage about what it really means to try to start a screening program. And so we're going to get started here today. And what I really want you all to understand is the nuts and bolts of starting diabetic retinopathy screening, something that we do, something that we know, but something that is really not easy. And these folks are excellent, and they are excellent at doing it in the safety net. And so we have celebrated programs that have been established, like Dr. Daskivich's program. We have academic programs funded by the CDC, that's Paula Ann's program, and a new kind of up and coming program that's a partnership with organized medicine. And so we just want to hear today, and for you all to be able to learn, what are the nuances of that. And I think I said I was going to start with Dr. Newman Casey. Is that right? Or did I say Daskivich? I think Newman Casey. So let's start with Dr. Newman Casey, and then I'm going to get out of here so you guys can get going. That's it. Let me stop sharing.
Okay. Let's see. All right. Well, the first thing I'd like to say is just to thank Dr. Wanyu from the bottom of my heart for inviting me to speak. This is a topic that's very close to my heart, and the one thing that Dr. Wanyu forgot to mention in my bio is that we were residents together, and we were buddies. Where you have like a buddy with a first year and a third year, and so we got to spend a lot of time together in the hospital. And so I think all of our chatting really kind of highlighted both of our passion for seeing medicine and seeing the world in a little bit of a different way, seeing how we could make it a little bit better. So, okay, how do you build an eye disease screening program? These are my financial relationships. Um, Nothing that I'm going to say is representative of any of these institutions. So what I wanted to start with is relationships. Obviously, the first relationship is with Dr. Wanyu, bringing me to this, starting as residents, and then coming along this journey of thinking about how can we impact healthcare delivery, and the relationships also were really important in starting all of my outreach work, even though a lot of it is kind of scientific at this point. How it started was just when I was a fellow, the chair asked me if I was interested in running an outreach program for the Kellogg Eye Center, and seeing all of the referrals from our local free clinic because they didn't have any subspecialty equipment at the free clinic, and they had a list of 250 patients who needed an eye exam. And I said, okay. So, so I worked with the university leadership, and we got volunteers to come 4 Saturdays a year at the Kellogg Eye Center. And we see all of the referrals from this local clinic. And at this point, we've been working with this clinic for the last, let's see, since 2011, so about 14 years. We've seen about 1,700 people. We've given out 555 pairs of glasses. And what's really important is that we've signed up 344 people for charity care so they could get definitive care through the U of M. And this is the relationship that really set the stage for being able to expand into thinking about how do we not just have a little band-aid clinic with a kind of our local free clinic and a partnership with the university, but how do we then expand this into the rest of the state? And so that's another story with relationships, and this is where trust and relationships are so important. Dr. Leroy Johnson was a community ophthalmologist in Flint who retired and then went back to work at the Hamilton Community Health Network and worked there for 11 years. And at that time, he would refer patients to my mentor, Cy Maroy. And when Cy heard that I let her know, and she knew that there was this opportunity from the CDC to trial a new way to do eye disease and glaucoma screening in the community. She said, "Hey, Paula Ann, why don't you reach out to Dr. Johnson and ask him if he's interested in collaborating?" And because he already had a relationship with Dr. Moray, already had a relationship with the Kellogg Eye Center, he, of course, said yes. And that was guided by Mr. Clarence Pierce, who's the CEO of the Hamilton Community Health Center, who's really been a visionary in this space. Not all federally qualified health centers and community health centers have the bandwidth to take on subspecialty care, but Mr. Pierce really feels strongly that it's important to provide subspecialty care within this primary care centric health network. So, what is a federally qualified health center? Federally qualified health centers are primary care based community clinics, and they provide medical care in underserved areas regardless of your insurance type or insurance status. So, they're providing care to people who are living in poverty, and they're federally supported, and there's a lot of them. They're all over the United States. There's about 14,000 clinics spread throughout the United States. And so, who do they serve? Well, if we think about the US overall, in 2021, 12% of Americans live below the poverty line, 8% were uninsured, 19% had Medicaid, and 18% lived in rural areas. When we compare this to the FQHC population, 63% live below the poverty line, 22% are uninsured, 44% have Medicaid, and 42% live in rural areas. So, federally qualified health centers are serving people who are at very high risk of underutilizing eye care and having undiagnosed eye disease. So, this is a map that shows how many federally qualified health centers throughout the United States have eye care services. Doesn't necessarily mean that they have an optometrist or ophthalmologist on staff. It just means that they have some kind of eye care services, which could be a diabetic retinopathy screening camera. And yet this map is a little bit um, uh, it's a little bit controversial because when you look at this map, it seems like there's a lot of eye care in federally qualified health centers. But when we do the analysis, it turns out that only 2.6% of people who are seen in federally qualified health centers are actually receiving any form of eye care, and that includes camera-based diabetic retinopathy screening. So, what did we want to do? We wanted to see if we could use the VA model of technology based eye disease screening uh, in this federally qualified health center, where an ophthalmic technician in a really small screening space in this primary care clinic measures visual acuity, does a refraction, checks for an APD and narrow angles, takes pressures, pachymetry, fundus photos, and an OCT, and helps the patient choose glasses. And in our program, people can choose low cost glasses from Zenni, which is an online retailer, and the ophthalmic technician assists the patient in placing the order and fits the glasses once they arrive. So we saw about 4,500 people over 4 years in this CDC demonstration project. And we stopped our data analysis at about 3,700 people. And among these folks, the rates of screening positive for eye disease were way higher, significantly higher than national averages. The rates of visual impairment were twice as high, the rates of glaucoma were 3 times as high, and the rates of diabetic retinopathy were 1.5 times as high. We also had those folks come back a year later to see if participating in our program that included this care navigation and access to low cost fashionable glasses impacted people's vision. And we found that people came back with better vision, and they came back with better vision related quality of life and less worry about eye disease. And so, of course, this takes a team and it takes relationships and it takes continued effort. And so, this is just want to make sure I acknowledge and thank the wider group of people who are responsible for making this happen. And right now, we are embarking on a pragmatic, randomized, controlled clinical trial to compare an optometric exam without any technology based equipment to a protocol based, technology based optometric exam, the same one that we used in the MySight program, to see if we detect more diabetic retinopathy, glaucoma, and visually significant cataract when a federally qualified health center actually has access to the technologies that we use in our clinics every day. Um, so with that, I will thank you for listening and turn it over to
Yes,
who's
so now we're
next.
gonna have Lauren.
All
So we're
right.
gonna have Lauren, and thank you so much for that. And then you can put your questions in the Q&A if you have something while they come up, and we'll let the speakers keep going.
Hopefully you are seeing my screen now. Is that right? And give me a thumbs up if so, at least those of you that can see. Then Pollyanna, so it's okay. Hopefully, good. Okay, hopefully it's there and on presenter view, which was my intent. So thank you so much to Dr. Wanyang for having me here today and for starting this Eradicate TRD series. It's really exciting to be able to have a platform to share the lessons that we've all learned and hopefully learn some ourselves. So I don't have a ton of slides today, but I'm going to start out talking a little bit about the screening program that we've created here in LA County. Um, and the lessons that we've learned in doing so. And then I know that we'll have a lot of time for discussion on the back end. So I thought it was important, though, to start with some information about LA County and the background in which we've done this work. LA County is large, population of 10 million. which would be the size of the 8th largest state if we were a state. And we have about 10% of patients that remain residually uninsured after the implementation of the Affordable Care Act. Around 42% of people in the county are on Medicaid, or in California we call it Medi-Cal, or some form of that. And that translates into, for our patient population in the Department of Health Services, where I oversee eye care, that's about 70% of our patients are Medi-Cal patients. So the Los Angeles County Department of Health Services is the main safety net provider here in LA, and the second largest safety net provider in the US. We see about 600,000 or so unique patient visits annually. That can fluctuate a bit depending on the federal programs and the status of CMS. But again, as I mentioned before, and I put a little definition up here of the safety net for those that are not familiar with it, but I imagine that most all of us are. It's the area that we work in providing care and services for underinsured patient populations. So I think it's important also to understand the types of facilities that we work with in providing this care. So the Department of Health Services provides care, and that includes eye care, in a number of different types of facilities. We have 4 larger medical centers, hospitals, where we provide tertiary level specialty care as well as inpatient care. Our multi-specialty ambulatory care centers provide kind of all levels of specialty care, and often higher levels, tertiary level specialty care, but don't have an inpatient arm. And then we have 17 comprehensive health centers that are under the Department of Health Services, and those are a lot like the FQHCs that Dr. Newman-Casey talked about. And then we also partner with actual FQHCs out in the communities and provide their specialty care whenever a lot of their basis is primary care, or some will provide a bit of specialty care here and there. And so many of those probably showed up on that map that Dr. Newman-Casey just showed. And then we also provide the clinical arm for the Department of Public Health clinics, and also all of correctional health. So we take care of the jail and juvenile hall patients. That's what it looks like in words. And in terms of the physical geography of LA County, we're about the size of Rhode Island and Delaware put together. Again, LA County is big. Wasn't born and raised here, and I'm continually impressed by the size. And its geographic landscape ranges from very rural up in the north. We even have a little mountain range in between, and then you can see the south is very urban. So we do get sort of all sorts of the challenges that come with both rural and delivery of healthcare in both rural and urban settings. And all these little points on the map are the clinics that we either partner with or run ourselves for providing healthcare to patients. What does our patient population look like? Who do we serve? I think these graphs tell a bit of the story. You can see our patient population, again, primarily immigrant, skews younger. We are predominantly Hispanic, Latinx. I always am a little entertained by this pie graph that shows that we're about 50-50, at least on paper, in terms of the languages of our visits. But I will tell you, as a clinician in our system, it is majority Spanish speaking, and I probably spend 80 to 90%, if not more, of my day speaking Spanish. So I'm sort of surprised to see that that is 50% on paper. But there you go. And then in terms of our payer type, I know this can be, my graph over to the right can have a lot of information in it, but if you look kind of at the blue-gray color on down, that's all some type of Medi-Cal. So that's like the 70% that I mentioned before, forms of Medi-Cal, and then the rest of it, that other sort of 30% or so, is a large chunk of uninsured, a little bit of Medicare, and a small amount of the rest. And that pretty much holds steady across inpatient, ED, hospital or outpatient, where a lot of our hospital, outpatient, or ambulatory care network. And those last two are where a lot of our eye care is provided, and our primary care as well, which is pertinent for our LA County DHS teleretinal diabetic retinopathy screening program, which I began in LA County about 12 or 13 years ago now. This slide, I've included sort of the larger building blocks of this program. It has gone through a few evolutions over the years, and I've certainly learned a lot. I know we'll talk more about these, I assume, in our discussion today, so I'm not going to go through each one of them. There were years behind probably every one of those building blocks to get us to the place that we are now. But I did want to take this time to describe just a little bit about what our program looks like. It is a primary care-based teleretinal screening program. Again, began as a diabetic retinopathy screening program, but now that we've been entrenched in this paradigm of providing our screening care in primary care for a number of years, we've begun to move into other eye care diseases as well. But it is, we take images with a retinal camera in the primary care clinics. We certify our photographers, but they are all primary care clinic staff, mainly medical assistants. And they take a vision and an image, and this is then transmitted remotely through our software platform, our secure software platform, to our certified readers, who are actually all optometrists that are employed in the Department of Health Services system. But they are specially certified as readers in our program. And because they're optometrists, again, the basis of the program was for diabetic retinopathy screening when we began, but they're able to pick up other eye care, other ocular conditions on the images. And so we are able to detect more than just diabetic retinopathy. And one of the critical pieces of our program has been standardization. You can see it gets its own box in bold there. And that has really helped us maintain the quality in this size of a program across such disparate settings. So we love our workflows and our protocols. And it's really been, I think my motto in this work has been finding the right balance between standardization and flexibility, because not every clinic is going to be the same, not all the settings are the same, they don't always have the same amount of staff or the same location, the same rooms, the same dark settings or not dark settings available to them. So there is a piece of a flexibility that needs to be in there, but the standardization is critical to maintaining quality. And part of that standardization are established reading workflows. So our certified optometry readers grade our images, both for diabetic and non-diabetic disease, according to a standardized, and they give a standardized assessment and recommendation, where we triage patients to different levels of the eye clinic and for abnormal results. These are then transmitted, these assessment recommendations are transmitted back to the primary care clinic, where a referral is put in by the photographer for that follow-up care according to the triage guidelines that we specified. And this can happen in a number of different ways. In our own clinics, it is done through a e-consult program. So that's an electronic referral program. So we can track these referrals and then whether or not the patients get their follow-up visits. And so this is really just kind of my ending summary slide here. But I really feel that having this, a paradigm shift towards this being the way that we provide screening throughout all of the clinics for whom we serve, it's really provided a more equitable framework for not just screening, but also the way that we are able to provide eye care to this patient population as a whole. It's helped us in a lot of ways. And in no small part by increasing disease-based collaboration between our primary care and eye clinics, which I think is really essential to helping us care for our patients as the holistic beings that they are, but also very important in something like diabetic retinopathy or diabetic eye disease, where systemic care of the patient is so critical and important in their outcomes in terms of their eye disease. So I provided a little breakdown in terms of the our program outcomes over the years on these pie charts on the right. And the outcomes have really remained steady over 10 plus years. So we've seen that our non-referable eye disease, for most of 75% of our patients going through our screening program have had normal screens. And so we haven't had to bring them into eye clinic. And then about 9% have other referable conditions. And again, we're becoming more and more robust in our screening for other eye care conditions like glaucoma. And then we have about 16% that have had referable diabetic retinopathy. And you can see, the majority of those was moderate, and then about 7% with what we call referable or vision-threatening diabetic retinopathy, which is your severe NPDR, PDR, and diabetic macular edema, that we can then transfer directly into ophthalmology clinics, whereas the moderate will go into optometry, and our more severe vision-threatening disease goes into ophthalmology clinics, where they can get the treatment that they need in a timely fashion. So overall, this really has helped us not only improve our screening rates, but also through triage, resulting in improved access for all of the patients that go through our screening program, And by preserving visits for those patients that did not have any referable eye disease, we've been able to improve access for all of our patients in LA County. So it's helped us increase detection of patients with significant disease, not just diabetic, but otherwise as well, but other eye diseases as well, greater numbers of patients getting treatment, and providers working at the top of their skill set, which is really important in a limited resource setting like the safety net. And in part of that, we're also able to benefit from cost avoidance. We've been avoided the futility of treating really advanced disease when we're not getting to patients in a timely fashion and not able to really take advantage of the preventable nature of diabetic eye disease. It's also, we've seen the effects in decreasing societal and economic costs of blindness, but really especially for us in our system, we decrease the cost to the health system of having expensive specialists do the screening and preserve their time to do the more advanced care and management that they need to do for higher levels of disease. So I put, listed some of our publications there where we give the statistics on these things that I just mentioned, but again, eliminating the need for over 200,000 visits has really helped us in achieving our goal, which is overall to improve access to eye care, decrease cost, and improve the quality of care that we're providing to all of our patients. And so this screening platform has given us a great ability to do something like that. And I'm excited to talk more about it for the rest of the time that we have. And I will now relinquish the stage, if I can find all my buttons.
Yeah, we're going to have Dr. Sean tell us about his journey, and then we're going to chop it up for a little bit. So exciting.
Okay. First, I want to thank Dr. Wanyiwu for inviting me to share a little bit about what we've been doing in Delaware with you all today. I think it's really inspirational to hear from the other panelists who've been doing this type of diabetic retinopathy screening work for a much longer period of time and have been so successful in really reducing preventable blindness. And really that's the goal of any, diabetic retinopathy screening program. I think as many of the people on this call know, if we want to eradicate the TRD, we really have to win the battle in the primary care clinic and not the retina clinic. So, it's that screening piece that's so important in identifying these patients who might not have any symptoms of their disease and, might only come to ophthalmic care because of what's found in a screening program through their primary care clinic. So I'm in Delaware, a small state in comparison to LA County and Michigan, but we've been doing some exciting stuff that I want to kind of fill you in about. So starting in around 2023, the American Academy of Ophthalmology and the Task Force on Federally Qualified Healthcare Centers wanted to do a pilot study looking at diabetic retinopathy screening in FQHCs. And we in Delaware were interested in perhaps being a pilot site. We're a small state, and so it maybe made sense to start small and then try to generalize the findings from a small pilot program to something that could be more generalizable to a larger population. So we're currently in the second year of what initially was going to be a 2-year pilot study looking at AI-based diabetic retinopathy screening at a local Delaware FQHC. So the partners in this include our local federally qualified healthcare center, Henrietta Johnson Medical Center in Wilmington, Delaware, the American Academy of Ophthalmology, and Eye Care America, which is a public health charitable service program that's been in existence since 1985. And this is a network of ophthalmologists who have agreed to see patients who are uninsured and provide medical eye care to those patients free of at no out-of-pocket cost to them. So they get a free eye exam. And so the other partner in this is iNook, which is a company that has developed a AI-based diabetic retinopathy screening software that can look at fundus images and autonomously detect the presence of more than mild diabetic retinopathy or vision-threatening diabetic retinopathy. And then the Delaware Academy of Ophthalmology, many of our ophthalmologists are Eye Care America volunteers and have agreed to see patients who are referred to them as part of this screening program. So this pilot program provided our FQHC with a fundus camera and iNook's cloud-based AI diabetic retinopathy screening software to detect more than mild and vision-threatening diabetic retinopathy during primary care office visits. And the nice thing about this is that, the patient and the primary care doctor are immediately notified about the presence or absence of diabetic retinopathy. So these images don't really need to be read. The patient and the primary care provider at the point of having the image taken know whether or not there's diabetic retinopathy that needs to be followed up on. And so those patients with either diabetic retinopathy or ungradable images, for whatever reason, are then referred to an Eye Care America volunteer ophthalmologist using a web-based referral platform. And it matches an ophthalmologist to them based on their geographic zip code. So they're ideally referred to an ophthalmologist that's close to them, easy for them to get to. A little bit about the initial outcomes of this pilot, looking at a period of time from March 2024 to July 2025, we've screened 438 diabetic patients. About slightly less than 60% of the images were gradable. And surprisingly, or maybe not surprisingly, if you're in the space, there was a tremendous burden of disease in this underserved population. So 35% of patients with gradable images have diabetic retinopathy. 50 patients were identified to have vision-threatening diabetic retinopathy, and 41 patients were identified to have mild to moderate diabetic retinopathy. And then from March 2024 through April 2025, 61 patients were referred to an Eye Care America volunteer ophthalmologist through the web-based Eye Care America referral portal. Obviously room to improve the follow-up piece, and I think maybe we can talk about that further, but, only 17 of these patients completed their follow-up. 28 patients no-showed or canceled those appointments. And so, we're losing a lot of patients who really need eye care and, have vision-threatening disease just because they're sort of lost to follow-up and it's sort of fallen through the cracks, so to speak. So, that is something that, we're certainly actively working on and improving in this pilot study. So I think, just briefly, some of the takeaways from this, small pilot study, clinic buy-in is something that you might take for granted initially, but it's really not automatic. You're asking already busy, FQHC clinic staff to do like one additional thing. They're already doing blood pressure, they're managing patient phone calls, and then, you ask them to take some photos and and fill out this web-based referral form. It can be a lot. And so, there is a little bit of resistance to sort of adding one additional thing on the plate of the medical assistant or the nursing staff at the FQHC. So we really found that by having like a weekly, just brief, like 10-minute huddle call with the FQHC staff that's actually doing the photos, that really helped kind of identify some, kinks in the workflow process and sort of smooth over some of the bumps. And, people could, maybe air their grievances about what's working well or what's not working well, and kind of allowed us to find ways around the sort of pinch points in that process. Another thing that we identified pretty quickly during the first year of the pilot is that initially, Eye Care America was only eligible, patients were only eligible to use Eye Care America and see an Eye Care America volunteer ophthalmologist if they were 65 years and older. So obviously, we know diabetic eye disease affects patients of all ages. Certainly, working age people, are affected, and so excluding, a bunch of patients was not going to be helpful. And so, fortunately, we were able to go to Eye Care America with some of the preliminary data, and they have lowered the eligibility requirement to patients older than 18. So that is a tremendous benefit. Now many more patients are able to see an Eye Care America volunteer ophthalmologist and hopefully access care through that way. So we really appreciate Eye Care America's willingness to see patients 18 and older now. Obviously, underserved patients in this population have a high prevalence of diabetic retinopathy. Over 30%, 35% of gradable images had diabetic retinopathy, and it's a tremendous disease burden. I think we all the panelists on this call sort of know that. And the biggest barrier, as I mentioned, really, I think continues to be closing the loop on follow-up. And we have identified some ways to get around that. Uh, the patient gets the information with the ophthalmologist that they're referred to, and an email goes to the clinic of the ophthalmologist, the volunteer ophthalmologist who the patient is referred to. And we found that just by kind of going through patients who had been referred but not yet scheduled those appointments, having clinic reach out to those patients and call those patients, we were able to sort of increase the number of patients seen through this program. And then, as was announced at the annual American Academy of Ophthalmology meeting by Dr. McLeod, the CEO of the Academy, we were really excited that the Knights Templar Eye Foundation has committed $1.5 million to expanding Eye Care America and AI-enabled diabetic retinopathy screening across additional FQHCs nationwide. So there's going to be 2 additional pilot programs, one in Outer Banks of North Carolina and one in West Palm Beach, Florida. And, we're excited to see how this process can sort of be generalized to other communities across the nation. And that's all I had. So I'd be happy to talk more and discuss things and learn from our other panelists.
Well, I can tell already that we are going to run out of time because this is fantastic. You all have done some really, really hard work. Things that stick out to me are things that we know, but I think it's important to elevate. The burden of disease in the safety net is really high. So there are places around the world and in our country that don't experience the severe diabetic retinopathy. But I was just, blown away, Lauren, by the thousands of patients that have, severe disease, or, 35% of the gradable images that needed referring had diabetic retinopathy, 1.5 times in Paula Ann's. And I think the really kind of conceptualizing in this moment are patients that experience racism, poverty, xenophobia. They are carrying the burden of this disease. But what's beautiful about this moment is that I've been trying to conceptualize the opportunity. So I want to start with AI a little bit. And when AI, first started to emerge as an opportunity for advancing health equity, I wondered, like, how would this work, right? Because it learns from our current systems, and our systems aren't great for the safety net. So I would like you all to, really kind of conceptualize how you're thinking about artificial intelligence in this particular population. Lauren, I want to start with you, and then, Ben, I want to go to you, and then PA, if you have anything to add for us, we can. But remember, we have a lot to talk about.
Okay, I hear you. I won't take too long. No, I mean, I think AI, right? That is the hot topic of this, and especially those of us that have been in this area for a while, it's been an interesting challenge because we began without AI, right? Or when AI was in its really early stages. So the question becomes how to incorporate it and when. Not if, but when. And for me, that's been a special challenge here in LA. I think I have been very, very deliberate and passionate about, like you said, involving our patients in this, right? Because I didn't want AI to be developed elsewhere. Now, we have to be very careful with our vulnerable patient population, sharing data privacy, data security. But, I've worked with a lot of these companies. Even though I don't actually use AI in our program right now, I worked with Kaushal and iNook from the beginning because I think it's very important that our patients are represented in this data, that these algorithms aren't developed on patient populations that don't look like ours. And then later that's imposed upon them, right? I think that we've learned I hope that we've begun at least to learn our lessons in that area, that these things need to be equitably, represented, because AI, like you said, Kristen, is only going to reflect what you feed it. And so if we're not representing our patients in the development of this, which often the safety net can be neglected in research and development, then we're doing our patients a disservice. So I have tried, and I've worked with it, not just iNook, but a number of companies in development to make sure that patients that look like, at least the LA safety net are represented. I think some of the challenges in implementing AI for us are that, we began our program some time ago, and when we began it, we do have, optometry readers. And so we're able, part of the strength is the level to which we can provide triage. And so, a lot of the AI, at least with its FDA approval, when it was first coming out, it was like red light, green light, right? But we are like we triage down based on like the level of disease that you have, right? So if it's no or mild disease, we know that's okay to come back for photos. If it's moderate disease, I want you in an optometry clinic, not an ophthalmology clinic, but in an optometry clinic, and an optometry clinic where I know, my optometry clinics have gradations of abilities, right? Some of them operate in the tertiary center where they're right next to opto, and even if a PDR patient walks in, they can bump it next door and that gets a laser. Whereas some of mine are out in the ambulatory care network or in these FQHCs where they don't have that access. So there's still going to be a lag time with that next step of referral. So I don't want, a severe NPDR or a PDR landing there. So there was, AI wasn't as facile in helping us maintain that level of triage and that ability to get patients and slot them where we needed throughout LA County, which is one of the strengths of our program because it was remote, that we could actually maximize our capacity by using slots across the entire system. It's not just local. We were feeding this into like an electronic referral system where we could see where the capacity is and plug those patients in across the system. Part of the standardization, right? Like everyone is reading in the same language, so we can easily use, referral systems or other of any clinic to say where a patient should go. And I think that's kind of been, one of our bigger challenges with with AI and integrating it at that stage, because I didn't want it to have us go backwards, to be a red light, green light when we hadn't been. And then the other pieces also, that because we're using optometry readers, we were catching disease beyond diabetic retinopathy. The AI is getting there in all these things, right? Like it can identify things beyond diabetic retinopathy. We know that, but it's not, the FDA approvals weren't catching up. And we also wanted to be very safe and secure with our patients and make sure that we, the technology that we were using on them was more tried and true as it could possibly be. So it was sort of a, is a balance, participating in the research and development, but then also making sure that things were, more well developed before implementing them on a vulnerable population in the safety net. But for us, it is a win with AI, and I'm still in those conversations, but haven't figured out just the right time to do human-assisted AI, which would be for us, versus autonomous AI. But it will work at all capacities, and it's such an important thing, and it's really going to revolutionize what we've already been able to do.
Yeah, I love the intricacies of data sovereignty, right, in our communities that don't necessarily have the voice at that level to be able to talk about where their data goes, how they use it, and what happens to it. Dr. Shawn, do you have anything to add about, how you are using the autonomous systems and that piece of it? And then I have a special question for Dr. Casey, because I know she nerds out on this stuff.
Yeah, I agree with everything that Dr. Daskivich has said. Really, I think the benefit of the AI platform is really having the ability to sort of get the immediate result to the patient, and having both the patient and the primary care doctor sort of be able to flag something at the point that that photo was taken, that you have a problem that needs follow-up. So often patients with bad diabetic eye disease have no symptoms, or they have very mild symptoms, and so there can be a little bit of extra counseling that's done at that primary care office visit by the, by the PCP to sort of inform the patient about why they need to follow up, what the sort of implications of not following up might be. And then I totally agree, the iNote platform is FDA approved for glaucoma and AMD, I believe, in the European Union, but not yet approved for these indications in the US. And so it's interesting because actually where I am in Delaware, my hospital system has a fundus photo-based primary care screening diabetic screening program that's run by physician readers. So I read images. So it's interesting seeing the contrast between the AI screening at the FQHC and the sort of human, physician-led screening through the primary care clinic at Christiana Care. And I will say, we do identify a lot of additional pathology in these images, epiretinal membrane, glaucoma, you see, you get a lot of information from a fundus photo in a lot of instances. And then you can also sort of, really, contact the patient or contact the patient's primary care provider if you see something that's very concerning. You see all of a sudden there's, proliferative diabetic retinopathy on the entire posterior pole. This patient needs to be treated 3 weeks ago, or, maybe 3 years ago in some instances. So, you can really, make a difference in contacting those folks. But I certainly think there's limitations to the AI screening, and I think the advent is coming, but remains to be seen when it will catch up with the human screen.
And I'm going to give Dr. Newman Casey a chance to talk about glaucoma. She always asks me if she could talk about glaucoma, and I usually tell her I make glaucoma. We don't talk about it. But today, I think this is really important because where this comes up, particularly in our diversity of our standardization, is in our glaucoma imaging. And I always get so frustrated at when that bottom ticker comes out that says doesn't apply to Black people, when we know that the leading cause of irreversible blindness in Black people is glaucoma. So why aren't there any glaucoma in this data set? And it depends on your technology. I know that Dr. O'Reilly Knight really fought to get Black representation in his data set for the standardization of the imaging device he was working with, but that's not for all devices. And so when you think about like artificial intelligence and how to incorporate that, I wonder, Dr. Newman Casey, do you have anything to add about kind of, how we can do that, or like, how to do those data sets, or to think about that? Softballs for you. That's an easy question.
Thank you for that lovely question. You know it, we've thought about this a lot. And I think Dr. Daskivich has already really just hit the nail on the head with her description of, you have to be careful when you're using an algorithm that wasn't developed in the population that you're screening. And so we have to be really thoughtful about what populations' data are included when these algorithms are made. And it's also sometimes shocking to think about, for example, in like glaucoma world. So I'm sorry to intervene, but you guys have been so kind to mention that when you do DR screening, it's really nice to find these other diseases too. And that's something, as a side note, with a lot of the current government's interest in diabetes, I hope to also bring to the forefront where we can screen for diabetic retinopathy, and it's super important. We don't want to see these TRDs, and it's lovely to also catch the other eye diseases. So when you just have a diabetic camera, you're oftentimes missing these other eye diseases until we move the next paradigms forward, where we can catch other eye disease, or at least have there's a Goomba there, AI. Can you refer to a reader to figure that out? But going back to your question, Kristen, which is really, how do we think about developing inclusive databases? And I think we see this problem more broadly, not exactly in fundus photos in the glaucoma world, because those algorithms haven't yet come out. But where we see those problems right now is in our OCT and in our normative databases for OCT. And because OCT is so nice and seemingly objective, it's very easy to rely on it for screening. And yet there were very few eyes used in these normative databases. It's like the company that we're using, TopCon, I think there's 400 eyes in the normative database. So no matter who was included, I mean, what kind of diversity are you really going to capture with 400 eyes? So I think it behooves us as a larger ophthalmic community to think about combining data and federated learning, and like just amassing large amounts of representative data to create these algorithms, and including all of Dr. Daskivich's and Dr. Chan's and Dr. Wanyewu's wonderful work in clinics, and putting all the data into these algorithms. And Dr. Daskivich, I think it would be fascinating if you could talk a little more about your work with these companies to try and make sure that your data was included. I think that would be informative for all of us.
Upward.
I'm looking at Kristen. Make sure I have permission. Well, yeah, it's interesting. I mean, I do think it's a challenge, right? It's because we've touched on all the important things, but it is that we are stewards as physicians that work in the safety net, right? And some of us have grown up in it, and it was our communities as well. But all of us that are continuing to work in that area, we are stewards of our patients' data, and we need to be very careful with it. So it is this sort of push and pull to both want your patients represented, but to do it in a respectful way, because there's, the industry has different goals, right? And so I think this is a special challenge for those of us that are really looking to use this to expand our access and expand our capacity in the safety net, because this is the next wave. This is what's coming, and this will certainly help us do it, but we have to balance it with being careful and being good stewards of the data. And so that's really been my challenge. I think I've been lucky to at least have folks be receptive on the other end. These companies that I've worked with have fully understood. I think I've needed to have a conversation every time and no, I'm going to get on that webinar and let's look each other in the eye when I tell you that I need to have some sort of agreement with how my patients are going to benefit from what you're developing. I want them to be a part of it, both because they need to be represented in it, but I also want to know what benefit they're going to get from their data, from using their data, and from our participation, because this is very valuable, right? It's very valuable to all of us, and I know it's valuable to them, but I need to be sure that my patients are going to receive something in return. So all of the participation that we've had with any of this work has always been with a guarantee that our patients will benefit from what is developed. I think my challenge now has been figuring out how to put that in place that still takes advantages of everything that we built, because we built it in a bit of a different time when that wasn't available. But I know that is the next step. And I think, y'all talking about glaucoma is really important, because we built a lot of what we did in diabetic retinopathy, but I built this with the idea that this is going to be a highway. Again, LA, so forgive my traffic is always top of my mind, but this is going to be a highway for how we're providing care, and then we're going to change the traffic that's on it. So glaucoma will be next. What other diseases can we get in there? Because this has made such a big difference for the way that we've provided diabetic retinopathy screening. And I know it can do it from these other diseases, but the challenges are different. And so having participation with experts like you, Paula Ann, has been so important in thinking about how we do this for glaucoma care, because the diabetic retinopathy was well studied. It's all sort of laid out. We can all agree on the factors, but then the new challenge is, what do we do when the standard still isn't really understood? And it's I always come back to this balance between standardization and flexibility, which is key both for operational and for implementation, but then it also becomes kind of part of this clinical care piece and the different populations that we're taking care of. And I think glaucoma is such a, it's so exciting and also so challenging, because this can make such a big difference in the glaucoma care that we're providing. We've seen what it's been able to do for us in diabetic retinopathy and getting to patients earlier, and we so need that in glaucoma, because now those are the ones that are coming into us too late. How do we get those, and how do we have the conversations at the level where we can bring your expertise into how do we do this, but in a way that keeps in mind the safety net and the capacity and what's truly possible here? Because yes, sometimes we want to treat these patients 3 weeks ago, but what do we really have the ability to do in the setting where we are? And you have to think about that when you're putting these programs in place. It can't just be the ideal. It's what can we really do, and what is possible both from the system standpoint and from the patient standpoint. Sometimes you can do the amazing thing, which is we'll see you this afternoon, and they're like, nope. I got to pick up my my kids or my grandkids or whoever. There's no one to stay with them. There's so many challenges that we think of beyond just the science and the disease. And so glaucoma, I feel is the new horizon that we really need to think about and tackle with expertise such as what you bring. So I'm very grateful for that, and looking forward to picking your brain more.
Yeah, all the things. I mean, I think elevating the data piece of it is really important. The beauty about data sovereignty and indigenous communities and how they get to think about data, but that's not transferable to our vulnerable populations and their data and how their data is treated. And, I love that the informatics world has principles about this, right? Fair principles, care principles, how you're supposed to be able to protect people's data, but our regulations aren't keeping up with that. And so I do agree that we have to be the protectors of those data. We have to be the keepers of those spaces and places as we, emerge, and that delicate balance is really important. Well, unfortunately, we are coming to the end. And so I know, how sad. This should have been longer. I want to talk to you guys forever. But I think in the moments that we have, and all of the humans that are here, thank you so much for your questions. What I'll do is, when we send out the summary, I will add the answers to some of the questions that we have left that we didn't get to. But I would love for our panelists to just take 30 seconds to say those kind of final nuggets, right? So say you're in a safety net setting and you're like, gosh, I really have to do this, and what are those nuggets that you want people to know when they are trying to start, one of these screening programs and the challenges. Dr. Sean, I'm just going to start with you. So, what are those things? You gave a good summary in your slides, but, if you would say that 30 seconds of, here are the things that you need to do if you want to start screening.
Yeah, thanks. I mean, I think the thing that made the most difference really for our screening program was really sort of getting everyone together in the same room and sort of going through sort of like a value proposition about, why, it's so important to catch these patients early. And I think, the patients and the providers know this, but maybe, some of the office staff and, may not necessarily have as much buy-in. So, when we really tell a patient story about, gosh, we saw this patient who had this vision-threatening pathology that you sent to us, and we were able to get them treatment with, injections and laser, and, it improved their vision, they had a great outcome. They go back and tell, their primary care provider that, gosh, thanks so much for catching this. I didn't really realize there was a problem. I think when you tell that kind of story to the folks in clinic, it really helps them understand, oh, this is maybe something that is actually important. We should take an extra, 5 minutes and get this fundus photo. We should fill out the referral form. And I think for that, when we got people together and sort of made them understand, the importance of some of this, it really helped us sort of increase the screening volume. It's challenging, I think, when you're starting these programs. There's, a lot of hurdles to doing anything new. Anything new in a new healthcare system is challenging. So the more you can do to just sort of be boots on the ground and get people together, I think that's the big takeaway that we learned through this program.
I love that. Dr. Newman-Casey?
I think that a focus on service and high quality service is really important. And serving people and meeting their needs where they are on that day, both the staff that you're working with and the people that you're seeing, because the word of mouth is based on the quality of the service that people are receiving. And that's what brings people in and brings people back. And the service extends from the diagnosis to also helping people get follow-up. So we have to close the loop, and we have to embed that in our screening programs, or we didn't get what we intended to do done. And I think we have that ability to provide very high level service, and that's what will attract people to us.
Dr. Daskivich?
Yes, I love all of those. And so I guess the one, if I have to say one thing, which you can tell is hard for me, I would say one thing that helps when you're building these things is to think about what is the win. And it's for all the different, because the win is different for different people, right? The win is different for the primary care clinic, and it's different for the patient, and it's different for the healthcare leadership, because you need all of that buy-in, like Dr. Sean said, right? You need buy-in from all of these people to make it work, and not all of their wins are the same. And you won't necessarily, so I guess you're getting a little bit into celebrating victories and acknowledging the valleys, that you may not be able to get everybody's every win, but if you can get a win for each and a solid win for each, then it really helps in getting these programs off the ground and in the sustainability of the program. So no one feels like it's something that's particularly forced on them. They all know what they're getting out of it and what it's bringing to the table for them, and will continue their participation.
I love that. Well, with that, I want to say, thank you so much for joining us. We are going to be doing this again next month. We're going to be doing eye care in the safety net. We're going to have representatives from Prevent Blindness. Kira's going to come. Dr. Elam from University of Michigan is talking about place-based care. Dr. Williams is going to talk about their safety net care at the University of Miami. And Dr. Lisa Kelly is going to talk about the safety net that she's built in Cincinnati. So we look forward to continuing these conversations. We hope that you will continue them. So, make sure that you sign up for this. We will engage you with this video when we get it, and it will be hosted on the Yale's YouTube site, so you always have access to it. And we just thank you so much for coming to our first one. So that is all, and this is our Scene Lab, so thank you so much for that as well. So there's our team doing beautiful things on our dissemination. So if you want to learn more about the Scene Lab, that's your code. And then here, but we really want you to show up next month and let's do it again. Thank y'all so much. This is where you cue the jazz music or whatever. I know, next time we do